Good afternoon, everyone. I'm Dr. Patience Atumanya. I'm an anesthesiologist at Uganda Cancer Institute. You're all welcome to this webinar. I suppose it's been a long time coming. So we are going to have a few panelists, with our main speaker being Dr. Arthur Kwizera. One of our, he's a critical care specialist based in Uganda, Makerere University. He has done a lot of work in Uganda with the setup of these ICUs that are currently around. His background training, he's an anesthesiologist with a linkage towards intensive care medicine. He's the founding president of the Intensive Care Society of Uganda. He's a fellow Thrive doing his PhD in collaboration with Cambridge University. He's also an expert at WHO for respiratory and COVID treatment guidelines. He's also a member of the World Federation Society of Intensive Care Medicine. And he also participated in the Surviving Sepsis campaign guidelines. He's also a member of that. And he's a frequently invited speaker in one of the conferences that is both European, American, with major interest to talk about ICU care setup in the low-income countries, especially Uganda. He participated in the setup of the International Hospital Kampala ICU, that is IHK, and managed it, and has been greatly involved in the setup of the ICU's construction in both Uganda, that is, equipping the Mulago Hospital, and also has been quite critical in setting up the regional referral hospitals and trying to see how we can get it up and running. We have three other panelists. We have Dr. Cornelius Sendagire. He's also an anesthesiologist/intensivist. He's a lecturer at Makerere University and has further training in both cardiac anesthesia and simulation, medical education and simulation from UCSF. We have Dr. Elizabeth Igaga. She's also a lecturer at Makerere University, and with interest is also in cardiac anesthesia. We have the last panelist, that is Dr. Agaba Peter. He is an anesthesiologist/intensivist with particular interest in neuro anesthesia, and he's also Makerere University. Now, let's dive into it. Today we are looking at what an ICU is basically, and I will let Arthur have a brief chat and tell us how all that is going on. But in brief, an ICU is a designated area in the hospital where you cater to patients who are critically ill, and with, of course, the resources and finances in these areas are a lot higher than compared to if you're on the regular wards. And just to give you a brief history of how ICUs came about, the first ICUs that were made were basically, I think if you hear about Florence Nightingale, she was one of the initial leads of how these ICUs were set up. And this was in the World War, where they designated a specific area where they could have the severely ill, the wounded soldiers get access to intensive nursing care. And that was the founding initially that it was not exactly intensive care medicine, but was intensive care nursing. But as time went on, with the advent of things like the iron lung, which was majorly used in the polio pandemic to ventilate patients, that and the utilization of other organ support facilities, that has since bred what we currently know as the intensive care. So this was what we used to call the iron lung. And if you have a look at this picture, this is how the patient will look like when they're in the intensive care unit. And this has since transformed to where you have an ICU bed that is almost comprehensive with all these gadgets that you see around. And the human resource has greatly increased. And now a patient can look almost as, happy or as awake as I look right there. Without wasting any further time, I will invite Dr. Arthur to take on the lead and get us through this webinar. You're welcome, Dr. Kuzera Arthur.
Thank you, Dr. Patience.
I'm not sure I understand.
I'm trying to share my slide, my PowerPoint. Can you hear me?
Yes, I can hear you clearly.
All right. Okay. So thank you for that very elaborate introduction. So I'll go right into it. What we are trying to do as the Association of Anesthesiologists and the Intensive Care Society of Uganda is to make this an interactive session. So what I'm going to present here, I will try and make a very quick show of it so that you, our beloved audience, can type your questions in the chat so that Dr. Atumanya can moderate, and then we can answer the questions on the go. I'm really blessed and honored to have my colleagues, Dr. Cornelius and Dr. Igaga, as well as Dr. Patience on, on the forum to moderate and also help respond to these questions. So intensive care medicine Uganda. Many of you know what has been happening. We know that COVID-19 has been ravaging the world. And I'm going to propose right now that we take a minute of silence for the people that we have lost. May their souls rest in peace. Amen.
Amen.
So,
Arthur?
yes.
Sorry to interrupt you. You need to speak a little louder. I think some people are not hearing you.
Oh, really?
Thanks.
You know,
yeah. But I can hear you fine.
Yeah, it's all right. It's just detach the the earphone. Can you hear me better now?
That's much better. Thanks.
Okay. All right. So, what is intensive care medicine? It's, forgive this for being wordy, but it's also a testament of how difficult what we do is. It's a branch of medicine that deals with taking care of really sick patients that need intensive and specialized medical and nursing care. And this branch of medicine has an enhanced capacity for monitoring and different ways of ensuring that our organs are taken care of during a usually short period of life-threatening organ system dysfunction. So I know that these are very difficult words for our audience, for some of our audience, but bear with us. At some point, you can ask any question that you need to know. But essentially, when any of your organs, and we know from our basic science that we have a brain, we have a heart, we have kidneys, we have a liver, we have lungs. These are the major organs that we have in our body. And then we have other organs that are also important that take care of us or our body functions. These organs sometimes, for one reason or the other, get disturbed, and in so doing, can cause us to die, can lead to our death if we do not do something about it. So intensive care medicine is the branch of medicine that looks after those organs, or tries to reverse their dysfunction for us to survive. So in intensive care medicine, or in medicine in general, we have what we call the concept of physiologic reserve. And I'm going to go and talk about the fact that every organ, and God made us in very special ways, that every organ that we have has an excess capacity to deal with any stress. And this is the reason why we have athletes, we have people who we call superhuman. Because in our day-to-day lives as average or ordinary human beings, we're able to go about our tasks without much bother. But we have people who do this because it's a sport, for example. And the reason I talk about breath holding is it's because it's the easiest thing that it's the easiest example to share. If I ask you to hold your breath for as long as you can, the reason you can do that is because every time your heart pumps, whatever you've oxygen you've taken in during the first breath goes to the tissues through your blood supply to the lungs. It goes to your tissues, to your leg, to your heart, to your liver, to your stomach, to any part of your body, and that blood returns to your lung after having a certain portion of oxygen subtracted from it. Our tissues never subtract 100% of what our bodies send to them. No. So, for example, you now know, many of us, because of COVID and the news, we now know the concept of pulse oximeters. Normal pulse oximetry reading would be something in the region of, let's say, 91 to 99%. If you send from your lungs to your tissue or to any part of your body oxygenated blood, that part of your body will subtract a certain percentage of that 90-something%. What will come back to your lung will probably be about maybe 78% oxygenated blood, and so on and so forth. And so what we call that, the ability, if you held your breath, you will not collapse, because you will have that reserve of oxygen in your blood with every beat. And so there are people who are able to hold their breath for a minute or longer, and we call that physiologic reserve. Now, every organ in our body has something similar. It means that if, for example, you get an infection, let's say a UTI in your kidneys, kidney infection, for example, and a certain percentage of your kidney is affected by it, your kidneys will still be able to perform their daily function because they have the ability to tide over their function because of what you call physiologic reserve. Now, intensive care medicine, and this physiologic reserve, we all get it at birth. Of course, as we grow older, the physiologic reserve drops. That's why when all of us, our Bakade or our Shwenkurus get ill, they tend not to do so well. It's mostly because their physiologic reserve has diminished. Now, other chronic diseases, diabetes, hypertension, and so on, are really a function of diminished physiologic reserve. I won't go into that because this is not a medical school session. We're talking about intensive care. So what happens in an ICU? If any patient is brought to us and they have diminished physiologic reserve, I like to use the lung because COVID is about the lungs, and this is where we are right now. Comes in with, let's say, with severe pneumonia, which is caused by COVID. COVID is essentially coronavirus-induced disease. So SARS-CoV-2 is a virus that affects the lung in a manner that causes inflammation. Inflammation is a state in which any part of our tissues responds to any insult. The insult usually is an infection. And what usually happens is for all of us who have had an infection, let's say I'll use our skin as an example, you get a boil. You get a boil, and inside the boil there is pus. What happens? A bug enters, the body recognizes that this is a harmful germ to our bodies and sends all these soldiers, also known as white blood cells, to fight them. As in every battle, like the old adage goes, when two elephants fight, the grass suffers. And so in this regard, pus is the result of that fight, and pus has to come out. Now, all patients that come to the ICU, many patients that come to the ICU need respiratory support. In our lungs, when we have two elephants fighting, what happens is, if we remember in our science, the air sacs, the distance between the air sacs and the blood supply to the air sacs increases, which makes it very difficult for oxygen to cross that barrier. And therefore, we need extra support for the lungs in the ICU in the form of different strategies. The most extreme is what we call a ventilator. So we have to put you to sleep, give you medication that numbs you, so that we put a breathing tube down your throat, which breathing tube we shall connect to a ventilator, which will put oxygen, through which oxygen will pass in different percentages of concentrations to your lungs and with added pressure so that we are able to oxygenate your body, a function which your lung has failed to do in under normal circumstances because of the inflammation. So let's assume you're a patient who has been admitted because of COVID-19, you can't breathe, so now you're asleep and you have this machine breathing for you. So when you come in, Dr. Agaba or Dr. Cornelius or Dr. Patience will receive you, will receive your family, a designated member of your family, and discuss with them your goals of care and say, look, Arthur is unwell, he has COVID-19 or whatever problem, and therefore he's ventilated. The goals of care are to enable us to hold his lungs, breathe for him, whilst whatever treatment we're giving against COVID-19 does its job. And we shall, every half hour, 15 minutes, half hour, check on him just to make sure that his lungs are starting to respond to therapy. There are many other things that happen in the ICU. And a lot of these are nursing goals. Nurses are the most important people in the intensive care unit. These are the people who are with the patient every minute of the patient's stay in the intensive care unit. When the management team discusses goals of care, the nurses are the ones who deliver those goals of care. It's their job to ensure that the drugs are given at every minute, every second. It's their job to ensure that the patient is responding, and their job to ensure that whatever monitored goals are documented, and if anything is out of sync with the goals of care, the doctor is informed. Now, during this time, the doctor reviews the patient every 15 to 30 minutes. There's a reason, and this is why we call it intensive care. If you had a call for a flu and you go to see a doctor for whatever reason, you'll go see the doctor will tell you, okay, this is your medication, after doing all the history, investigations, and giving you the treatment, and tell you, come back tomorrow. Or come back if you don't feel bad. If you're admitted, the doctor will come, do a ward round, make sure everything is fine, and go away, and you'll see them the following day. In the intensive care unit, the doctor, the intensive care doctor, the intensivist or the anesthesiologist sees you every 15 to 30 minutes. Because anytime the course of your outcome changes. And with that, that's the only chance you really have in life. Many people say intensive care is the the highest form of medicine. I'm not sure about that, but it's quite serious. The doctors will perform interventions depending on how you respond to therapy. One of the interventions, one of the most common interventions is your heart just stops pumping because it's tired. It's been tired by infections, it's been tired by inflammations, it's been tired by reduced blood supply, or your electrolytes are not enough, or your blood gas picture, or does not support its functions. And so you get what you call a cardiac arrest. Then they have to do CPR. You have seen what CPR is, I'm sure, in the movies. The other intervention that can happen is suddenly your kidneys stop functioning. And when your kidneys stop functioning, in the ICU, we have we conduct dialysis. The kind of dialysis is in an ICU is different from the dialysis that patients with chronic kidney disease or kidney failure get. This dialysis is what we call continuous renal replacement therapy, or CRRT. And this dialysis has to be done very quickly to reduce or to reverse the damage or whatever toxic load to your body is happening. The other thing that you need to know is that we do our work in ICU in 12-hour shifts, generally. That means that your doctor will do in an ICU, most ICUs have 8 to 12 patients per team, or even less. That means that a doctor and the nursing team will be in the unit for 12 hours, and the doctor and the nursing team, the nurses will be at the patient's bedside for every hour of those 12, for every minute of those 12, unless they have a bathroom break or a water break, to ensure that the patient is meeting the goals of care that we have set up in number 2. But also the doctors will come every 15 minutes, or sometimes even every 5 minutes, to ensure that the patient is reviewed and to review the patient and ensure that the goals of care are met. Because usually patients are really, really, really sick. So we've been looking at a lot of what is in the news. One of the things that people miss is what the qualities of a good ICU are. It's all well and good if a hospital sets up an intensive care unit, but what's the quality? What sets it apart? What standards does it meet to ensure? Because we are, as doctors, the only reason we exist is our patients. The first is nursing. And I forgot to write here that the ratio is that every patient who is in ICU, at the time they're admitted and taken care of, they should have that nurse on them, or the nurse should have them and maybe another patient that they're taking care of, depending on how critically ill they are. Those nurses should be trained or have training in intensive care. So the 1-to-1 or 1-to-2 nurse-patient ratio. In COVID-19, because of the severity of disease it is, we advocate for actually depending on how critically ill the patient is, we even advocate for 2-to-1, 2 nurses to 1 patient. So when you go to an ICU, you should ask them, is my patient with at least 1 nurse or a shared nurse? Secondly, the anesthesiologist intensivist should be there for 24 hours, meaning that whether it's 12-hour shifts, whether it's 8-hour shifts, there's a doctor in the unit at all times. Why? Because our patients change conditions unpredictably and almost usually irrevocably if they are critically ill. What does that mean? Patients in intensive care give us usually 1 or quite rarely a second chance at resuscitating them. If you're not there in that time, then there is a problem. If the ICUs do not have these doctors 24 hours in the unit, then you might want to ask some questions. Thirdly, the ICU care that these patients get should be protocolized and should be evidence-based and according to a set standard that is in line with current evidence bases. I will not go very much into that, Fourthly, you should get feedback every day. So what am I talking about? Family conferences. These family conferences, the ICU doctor should sit you down, tell you that, okay, this is the current, these were our goals of care today. This is where we are right now. What I found in my practice is to always say, you know, prepare for the worst, hope for the best, but give the real true picture. It's always going to be bad news anyway, but it's the truth. And even the Bible says the truth will set you free, or I'll paraphrase. The other thing is financial counseling. As doctors, there's a lot that's going around with regards to cost of ICU care. I'll come to that, but doctors are typically not involved in intensive care costs. It's hospital management, and hospital management has why they determine ICU costs. But what I always advocated for is to give what we call financial counseling. Explain to the attendants or the loved ones of a patient the costs as they happen every day, so that they have an idea of what's going on. We're a resource limited setting. So you're in a situation where even now, you have a patient in a private hospital, and the costs are beyond what you can afford. And then when you call the public hospital where the cost would be lower, they also don't have a bed. I've been in that place very many times, whether when I'm working in Mulago, or the time when I've been running an ICU, a private hospital ICU. The other thing is that the unit should have an in-house point of care diagnostics. That means that lab results should not delay. The intensivist decision making should not be impacted by delays in lab, because when your blood is, or whatever sample is taken, there's a tendency to mix it up with other what will I call them, other samples, and then there is a delay, and yet we need real-time decision making that is informed by diagnostics. So when I say ABG is having arterial blood gases, nowadays arterial blood gases can even tell you your kidney functions. So if you do not have that in your unit, then you know you have a problem. Lung ultrasound also tells you what's going on, but there is what we call POCUS, point of care ultrasound, where you can actually look not just at the lungs, but other organs to get a sense of what's going on. Dr. Cornelius and Dr. Igaga are experts in cardiac ultrasound. They may allude to that later. Audits. Audits are very important in telling us where we went wrong. In intensive care, patients die. We're not God by any means. We're God's vessels. And sometimes if God has decided, or for whatever reason, a patient passes on to the next life, we have to ask ourselves where we went wrong. And that's what we call an audit. The ICU has to do an audit every time a patient passes. It's not just because first of all, we don't point any fingers, no, but it's in respect to the patient who has passed, because we're going to learn something from them so that we are better for the next person. But also, it helps us come to terms with our failure. It's a very good way of saying, you know what, whether you're doing very well or very badly, you can get better. The other thing is, for most ICUs, and this is a global number now, all-cause mortality rate should be less than 20%. If you go to an ICU, ask them with all these questions, ask them, so what's your mortality rate? If it's more than 20%, you might want to ask yourself to go back and revise the questions above. I've delayed, I've spent quite a bit of time on this aspect, because at the end of the day, if you're going to pay a lot of money, because it's expensive, we say intensive care is expensive care, at least make sure that you're getting value for it. So, cost. One of the things that we tried to do around 2017, 2018, I also went back to school and learned a little bit of business and financing, was to try and find a way of making intensive care cheaper for us all. In a private hospital, we did an audit on the books of that private hospital. They graciously permitted us to look at them. And then we decided to look at road traffic injuries. Now, these are head injured patients who underwent some degree of head injury management in theater, and they ended up in our ICU on mechanical ventilator. The average cost to the hospital, not to the patient. That means buying drugs, paying the doctors, paying for the consumables that were used in the operating theater or wherever, was 3.7 million shillings per day. The typical average head injured patient stays in ICU for about 7 to 12 days. So that means that they'll spend that the cost to the hospital is about 40 million. Now, the hospital can decide to put its markup depending on its business model. And that means that your patient will pay, if hospitals say we'll add 25% or 30%, it's entirely up to us to do the math. One of the largest costs is human resources. This includes, for this particular case, was the neurosurgeon, the intensivist, the nursing care, the theater staff, and so on. Head injured patients are really, really sick patients, and they get quite a bit of attention. And I think human resources accounted for probably about a third of the total costs. The other costs were mechanical ventilation and continuous hemodialysis, because typically head trauma patients get acute kidney injury and need some rescue therapy with dialysis. But they typically do not develop chronic kidney disease where they need to be on dialysis for the rest of their lives. Usually this lasts 3, 4, 5 days. And then infections, they get sepsis and they need additional support as a result. So let's talk about Uganda and where we are as a country. In Uganda, the first ICU was set up around the mid-90s. I was in medical school as a first year undergraduate. And this ICU was a renovation of an old unit that was led by a Dr. Kiria. But this new unit, because I have to talk about what I remember, was a donation was a JICA, Japanese aid, something. And it was a 12-bed unit that was led by Dr. Catherine Omaswa. For those of you who know Dr. Omaswa, the cardiothoracic surgeon who was involved in setting up the Heart Institute. And later, this ICU was there. It had dialysis as well. It was a fairly decent ICU. And later, we had Lacho Hospitals set up an ICU, which I'll talk about. And then in 2007, we had International Hospital setting up an ICU that was in response to the open heart surgery initiative that they had. So when we talk about why and what happens in this dynamic, Africa has, most of Africa has, and a lot of, because intensive care was anesthesiologist founded and built, the model is pretty Commonwealth. Most anesthesiologists, because of the work that, the skill set that anesthesiologists have, they're quite key in running ICUs. And their training runs with that particular model. And therefore, as a result, like our Minister of Health was saying the other day, one of the reasons we have challenges in setting up ICUs is because there's not enough anesthesiologists. In 2007, we had only 11 anesthesiologists for 30 million people that time. And there was one ICU trained nurse who was the late Sister Elizabeth Naigaga. Now, who are anesthesiologists? In simple terms, we put people to sleep in the operating theater. But by and large, for the purpose of this conversation, experts in organ dysfunction management. Organ dysfunction is essentially when something goes wrong with your heart, your brain, your kidney, or whatever it is. And so we're experts in the emergency care, in resuscitation, in the first bits of when things go wrong. We are not that good with when things have gone wrong for a very long time. For example, if you're long-term hypertensive or whatever it is, no, that's not our remit. And therefore, we work in the ICU, we work in the emergency areas, and of course in the operating theaters. So if you need, commonly, if you're being put to sleep, for any major surgery, or if you need painless labor, if you're going to have a baby, or if you need a C-section and as people call it, half anesthesia or partial anesthesia, then we do that. We're not very many. I think as of now, we're probably about maybe 60 active anesthesiologists in the country. It's an extremely stressful job, and we have the highest suicide and alcohol abuse amongst health workers around the world. So back to Uganda. This is Dr. Towe and Ojara in Lacho. This was the first case of intensive care when Lacho was setting up. This Gloucester vent is an anesthesia machine that was also repurposed to do intensive care for patients in Lacho. And their focus was mainly on tetanus patients, and they did pretty good work with them. 2 years ago, Dr. Tumanya, who is our lead moderator for this, did a study on saying, okay, let's look at what the capacity is of our ICUs in Uganda. And our focus was in those that are functional. And we had a pretty defined criterion for this. Functional meaning they actually work, the doctors come, nurses come, patients come in and leave, and they're taken care of. And at that time, there were only 12 functional ICUs. And unfortunately, the majority were located in the central region. And we only had 55 ICU beds, which gave us a ratio of 1.3 or 1 million, or 1 bed per million, which was a reflection of, a low-developed, low-income country. Where are we 2019? At that time, then we had 12 functional beds. The Mulago renovation had gone on, and some pretty good work had been done by the Ministry of Health to do on that hill a 60-bed combined ICU capacity in the two complexes. We also have the first dedicated 10 to 15-bed pediatric ICU. And then for human resource, Busitama University inaugurated the Bachelor's of Anesthesia Science, which is also heavy in critical care, to help us bridge the gap. We have 3 pediatric anesthesia and intensive care specialists in the country. And then in response to the COVID-19 pandemic, there was a planned 10-bed ICU per regional referral hospital. So now I know there are going to be a lot of questions. COVID-19. In the ICU, COVID-19 is quite unpredictable. What we've observed is patients tend to deteriorate at night because of high fevers, and their oxygen consumption increases. Also, it's particularly labor intensive. There are both COVID-19 and non-COVID-19 ICU patients that have to be taken care of. Imagine the resource limitations I've mentioned before, and suddenly we get swamped with this disease. It doesn't bode well for patients in a country that has resource limitations, because even in private practice, the hospitals then have to contend with this, rent equipment, buy hire extra, and so on and so forth, which is something I'll tell you about costs. Typical patient in the night shift, a third are doing well, they seem to be holding well and gradually improving. A third are stuck. They need dialysis, other organs are starting to fail. And then the final third are not doing well at all and are probably not going to make it. I have left this here now so that we can respond to questions about intensive care, so that we make it as interactive as possible. And with that, I say thank you very much.
Thank you, Arthur. So we have quite a number of questions. I noticed that most of our participants are sending the questions in the chat room rather than the Q&A sessions. Please utilize the Q&A chat room or area so that we can easily get all your questions. answered. Now, we have the 4 panelists, that is Dr. Kwizera, Dr. Cornelius Sendagire, Dr. Peter Agawa, and Dr. Elizabeth Igaga. The first question we have is from Nakandi, and she says, you have talked about an all-cause mortality of less than 20%. Has that been achieved in a COVID ICU currently? Probably I'll post that to Dr. Agawa Peter. Dr. Peter. Dr. Cornelius, are you available to answer the question?
Thank you very much. So currently, we do not have concrete data to verify that, but based on preliminary data that we've seen from some of the ICUs, yes, there have been some ICUs that are registering a mortality about 20% or less. So we hope that data will be published soon. But for now, I cannot put my arm and leg to justify that. It's just preliminary data.
All right, thank you. I'll pose the next question to Dr. Arthur, if you don't mind. This is from Ntege, and he says his question is driven towards risk ICUs. How do intensivists or persons concerned go about this?
Yeah, thank you, Dr. Atumanya. Please repeat the question. You broke a bit.
Oh, sorry, my bad. So Arthur says that so his question is driven towards risk management strategies with the ICUs. How do intensivists or persons concerned go about this?
Okay, that's very broad. Risk management strategies. Well, risk management depends on the domain that you're applying. So, for example, we look at our areas of risk in terms of human factors, that's safety. So, in the intensive care is for example, infection control. So there are quality indicators that are applied. There are daily activities that are applied. And then when you look at the nursing, bedside nursing related things like, I'll give you, for example, a patient, self-extubations or patients pulling out, the sort of things that are patient induced. They are quality indicators, but they are also activities that are designed to deal with those. I hope that's what when you talk about risk management, I hope that was it. The other thing is obviously documentation all the time. The risks to an intensive care unit, include litigation, for example. The case of he said, she said, they said, this was done, this was not done. Everything has to be documented, and all parties, wherever it's documented, have to who witness and sign that they've witnessed. The other risk mitigation strategies are also to do with, for example, drug errors. And drug errors mean that you color code any intervention that you do. So the risk management strategies, that's a whole topic for intensive care, but I hope that I've sort of touched on how we do it. Over.
All right, thank you, Arthur. Dr. Elizabeth Igaga, I'm going to pose the next question to you. And this is from Caroline. What are the current key performance indicators of what you'd call close to an ideal ICU in Uganda? Dr. Elizabeth.
Thank you. Yes, thank you, Patience, for your question. I think that in Arthur's presentation, he basically went through most of the things that qualify an ICU to be called an ICU. That was one of his first slides. So basically competent nursing, the definition of what an ICU bed is. It's not just a nurse, not just a bed, the machinery, and then the different equipment and qualified people to take care of the patients. When you ask for key performance indicators in Uganda in particular, I think that I don't think that we have indicators that are specific for the country based on where we live, but we basically have standards that the World Federation of Critical Care and all those other bodies have set for us. So that is what we try to follow. If you asked me, do we have a perfect ICU in Uganda? Probably not, but we are working towards getting there. I hope I have answered your question. Cornelius, you seem to have something to say.
Not really, but okay, maybe just in addition, I think first of all, the question that was asked earlier about any ICU that achieved a 20% mortality, I think allow me to just expound on that. The person asking that question is probably asking because it's a bit surprising to see a mortality of less than 20% or less. And this is coming from a lot of data that we have from ICUs in low-income countries that have suggested or shown mortalities of 40% and above. And then, of course, recently, a study from that was done in mostly African countries, looking at COVID-19 outcomes, revealed there was a mortality rate of out of 10 people who enter the ICU don't make it out. And so it can be quite surprising to find a mortality of 20% or less. In other words, 2% of people who enter the ICU out of 10 don't make it out. These are the mortalities that are being seen currently in high-income countries, much lower mortalities now than in the beginning. Partly that can be explained by them not being overwhelmed as they were in the beginning, but also because they potentially learned their way to handle COVID-19 lung injury. So that is potentially the reasons why they're not seeing that much mortality. In our setting, naturally, we have a lot of limitations from resources, supplies, to the staffing that may be quite limited, and you don't have the appropriate ratios. And so we have a lot of system limitations that prevent us from seeing very good outcomes. However, if you are to venture into, of course, those limitations tend to exist in most of the public hospitals. But in a hospital where you're paying your money to earn a good quality care, and therefore you're going to demand for that, then they must provide what would be considered the minimum standards or the quality indicators of ICU care for patients. And so that means you're going to be looking at a one-to-one nursing ratio. And of course, that one-to-one nursing ratio is going to come with a fee and the cost that the patient has to bear. And then, of course, the treatment, the drugs, and everything that you require must be available. And there cannot be any excuse that the drug is out of stock or we don't have it in the hospital. If you're paying your money, you must get your money's worth. And so all that will be more available for you in some of the private hospitals. So unless, of course, in the public hospitals, because of the limitation that exist within our systems. So because of the high level of the pedestal we put the private sector on, they must be at the bare minimum, almost equivalent to with the care I would want to get if I was to travel out of the country. So that means that you'll find the mortalities potentially in the private sector could be lower than the public hospitals. And it wouldn't be surprising that some of the hospitals may actually register even much lower mortalities of less than 20%, simply because the indicators for quality of care are being met in those particular hospitals. That does not mean that any private hospital you're going to go to, you're going to get much better care. It doesn't mean that. It means you may get better resources, but the care may not necessarily be different. It also depends on the staffing that you have, the experience, the skill set that they have, yeah. So all that kind of plays into the outcomes for patients. So the more experienced the team is, the more they will potentially succeed in getting you off the ventilators and getting you home. The less experienced they are, that's the outcomes, of course, will be clear. But if you put an experienced team in a situation where they do not have the resources, then of course you do not expect to have good outcomes, because if I want you to drive a car and I do not give you the car, there's no point. That's basically the analogy that we can use at this point. I submit back to you. Thank you.
Thank you, Dr. Cornelius. I'll direct the next questions to Dr. Peter. These are from Peterson Mwesigwa. And he's speaking as a non-medic, why is it that the doctors never really come to communicate clearly that the person is dying or it's near the end of the road? Is it part of the medical training to be discreet on a patient's fate, in brackets, read to lie? Dr. Peter?
Please repeat the question. Hello, please repeat the question.
Oh, sure. Sorry, I was muted. Peterson is asking, why is it that the doctors never really come out to communicate to the family members that a person is dying or it's near the end of the road? Is this part of the medical training to be discreet on a patient's fate, or in brackets, read to lie?
Okay. Thank you for the question. That sounds like a general question about doctors in general. Well, I work in the medical school and we train anesthesiologists. We train them to communicate with the patient. And seeing that should be happening, and what I practice and what I know my colleagues practice is that the patients are and the relatives are given the information as we get it, and as best as we know it. So if we think a patient is not going to make it, we tell you what the chances are for them not making it, or where we think things are going to head. But again, they may be, most doctors are not going to be comfortable delivering bad news. And the general understanding is that people want to be given hope. So you may find some doctors will, even to the end, keep telling you the patient is going to get better, the patient is going to get better, when they know the patient is unlikely to do well. But in the ICU, we try to give you the facts as they are, and to give you our interpretation of things as we know them. We are not God, but we tell you what we understand of the things that are going to happen or may happen based on our experience and on our knowledge. Thank you.
Sorry, Peter, before you go off, Peterson went on to ask that all cases of, for all his friends that he knows who have been diagnosed with COVID and entered the ICU, they have all not survived. Do you have any success stories that you can give to him?
Well, there are lots of success stories. There's lots of patients who come out of the ICU. I don't have the numbers, but what you must understand is, of course, for anyone who gets that sick, the survival is usually going to be, what, maybe out of 100 patients that we treat, we are probably going to lose, what, 40 or 50% of those patients. So the mortality is quite high. It's higher than what you see with other sicknesses that don't require people to come to the ICU. So it is not, I mean, it's not surprising that for him to have seen a lot of his friends going to the ICU and come out and not make it out. What most people don't understand is it's not just COVID. COVID gives you what I would call critical illness. And critical illness is what I would describe as a let's say a steeplechase, or it's a race with many hurdles. So even though you may survive the initial course of COVID, there are lots of complications that come in, complications that may not be necessarily from COVID itself, but they may be from the type of care you're getting. Maybe you develop an infection, that sort of thing. And those may be the things that eventually cause death of the patient. So it's a lot more complex once you get that sick. It's not just the COVID, but there's a whole cascade of things that happen downstream because you've gotten that sick. So these patients are generally very difficult to manage. And going to the ICU really is we are playing a numbers game, really. We are saying, is this patient sick enough to need the ICU, but not too sick to not benefit from what we are doing? And if we feel that that patient will benefit from the care, then we say we should give this patient this care. But that is still not a guarantee that that patient will survive. The only guarantee you have is that the people in the ICU will do the best they can to give this patient a chance. Patients, I think that's it for me.
Thank you, Peter. The next question is from Dan Muramuzi. Dr. Kwizera, I think this is addressed to you. In your observation, Dr. Arthur, why has up-country intensive care units, especially the regional referrals, failed to meet basic ICU standards for low middle income countries? Because if he's not misinformed, it's only Mbara regional referral that is relatively functioning. How can we make them function?
That's a very interesting question. I wear two hats in this. One, in regional referral hospitals, in the Ministry of Health Service Commission framework, until recently, did not even have anesthesiologists or many other specialists as part of their armamentarium of specialists. And even when they did later, the numbers that they had proposed, it was just one per hospital. There was no plan to have an ICU until about 3 years ago. And a lot of this got accelerated with COVID-19. So one of the challenges we have is because we already have so few anesthesiologists in the country, we are not going to be adequate enough to cover the whole country. For us to cover the whole country, first of all, we have to saturate the central region, which is Kampala. And we need to saturate Kampala, which has the bulk of high-risk surgeries or high-risk intensive care and affordability as well for a paying population. You need about 300 anesthesiologists in Kampala. Before you start to say, oh, now we are saturating the regional referral hospitals. Now, this is not pointing blame in any sense of the word. It's just the way it is. The ICUs are not going to function. Every regional referral hospital needs at least 5 anesthesiologists because they have to take care of the operating environment, emergency environment, and the intensive care unit. And remember, intensive care unit is a shift system, day and night. And government workers do day, then they do evening, and then they do night. So they do, you have 3 shifts a day. So when we calculated, you would need 5 anesthesiologists per regional referral hospital for everyone to be happy. The patient, who is the most important person in this equation, then the nurses, who is the next important person, the doctors, and then the administrators. But the decision-making goes the other way, from the administrators downwards. So I hope that answers your question. We need more anesthesiologists. We need more people interested in their practice of anesthesia intensive care. Thank you.
Thank you, Arthur. Sorry. I'll direct the next question to Dr. Cornelius. So this is from Winnie. Her concern is the extreme bills that come along with the ICU care. Are there possibilities of you as an expert being able to predict the outcome? Could there be chances that you can advise patients not to proceed to ICU? And the example that is given is a COVID patient whose lungs may be extremely damaged, and it is confirmed. Why would you keep them on a ventilator well knowing that this life cannot be saved and bills are accumulating? Would you like to give more light? Thanks. Dr. Cornelius?
Oh, sorry, I didn't catch that. That was for me. All right. So it's a very good question, and it's one of those questions that we always have to discuss with the families. It is not straightforward. So let me kind of backtrack a bit. So why do we put patients on mechanical ventilators? Number one reason is that they actually need them. If the alternative of not having the mechanical ventilator would mean that you would have a few hours to live in most instances, because probably your oxygen levels are extremely low. And then, of course, the other reason that we put you on is that there is a very high probability for you to actually recover from that disease. And now the probability, like Dr. Peter mentioned earlier, is dependent on your state, your health status before you fell sick. And so if you are in a situation where you probably have a massive stroke and you're not able to move, you've been bedridden, perhaps in that situation, that's not the kind of patient you want to put on a mechanical ventilator, because they're unlikely to recover any meaningful life after they've suffered such a debilitating severity of disease like COVID-19. However, let's say you are a young person, about 26 years, and I mean, you've been enjoying your life, you have your future ahead of you, you have no particular health problems, and then you get COVID-19, and your lungs are extremely damaged. Have we seen patients who have survived with extremely damaged lungs? Yes. A 26-year-old, for example, who does not have any serious health problems to be worried about, has what Dr. Arthur described as a physiological reserve. In other words, their body can handle the strain of the disease, as well as the strain of the effect of treatment that we give patients within the ICU, which is usually very high-end and very heavy treatment on the body. So over time, when you're in the ICU, we have to keep gauging what is the probability that we are going to get off that machine. And these are things that we have to continuously discuss with the family. Of course, if you only have your lungs that are damaged, the current data at least suggests that patients who have severely damaged lungs and they're on a mechanical ventilator and they require a lot from the mechanical ventilator to just sustain the oxygen levels in their blood, their probable mortality is about 40%. And that is all factors constant, is about 40%. But that probable mortality is not necessarily applicable to individuals. In other words, each of us has our own chances. And that's why you require an intensivist to be available to make these assessments on the daily to see where we are going with the kind of care that we're giving a patient. Now, if at all you are to get worse, what tends to happen in COVID-19 is that there ceases to be a response to the mechanical ventilation. In other words, we have to ramp up the support from the machine to such an extent that the machine may start to pause injury to your lungs and to your body. And that injury, of course, can start with your lungs, maybe because of the too much pressure that the ventilator may have to push into your chest. It may start to cause lung injury within you, and we may start to see that from the way, from either some of your lungs may get a leak or burst and have a small leak, and therefore that may increase pressures in the chest and require us to put things like tubes in the chest to relieve the pressure. All of that is an indicator that, you know what, the treatment is probably not working. But for as long as you respond to treatment, then the point here is we have to continue providing that treatment. So to your question, why do we keep patients on mechanical ventilators even when the costs are ramping up, especially when we do not see the outcome getting better? I think the first thing you have to do as the attendant for that patient is to have a conversation with the attending team and find out how the patient is doing. Are they responding to the treatment? What are the signs that they're responding to the treatment? And therefore, what is our goal of care going forward? Short of that, and these are questions you have to ask yourself whenever you meet the team that is managing the patient. The response to the treatment is extremely important because that tells us where we are going. So in other words, if you do not have response to the treatment for maybe 48 hours, then it is very likely that you're not going to respond thereafter. Or it is likely that something else has come into the picture and the doctor has to tell you what that is. Sometimes COVID-19 patients end up getting bacterial infections, and that may worsen their oxygen levels outside COVID-19 itself. That may worsen their response to the treatment, and therefore some of them require a lot more support from the ventilator. But once we give antibiotics, it is potentially recoverable. So when we hit a point at which the patient is no longer responding to treatment and we've done everything we can, then this discussion is really to do with end-of-life care. And that becomes extremely complex because it's complex on both sides, both the healthcare team and the family. And why it is complex is at that point when you say, you know what, this treatment is not helping the patient, and I think we need to stop it, you have to be cognizant of the fact that the moment you stop that treatment, the patient is going to die. And that is something that is extremely hard for both sides, the healthcare team and the family. And no one really wants to make that decision. And therefore, the conversations with the families have to be ongoing until they both reach an amicable decision that will work. Now, of course, in intensive care, there is always room to withdraw treatments that are no longer beneficial to patients. But again, that has to be fully discussed with the families. And what we tend to do these days is we discuss with the families from the outset, what chances do we see this patient having in terms of coming off the ventilator? And so for those patients who are really, really sick and they have underlying medical conditions to start off with, we tend to do what is called a time-limited trial. Let us try this and we see what happens. If things do not go well, maybe day 2, day 5, we see then what to do. The options would be that maybe we withdraw the treatment and we let the person rest pain-free. So these are some of the things that you have to discuss, but these are ethical issues that are quite complex, and we have not exactly gone into discussing them for this particular talk, and it's a completely different and broad perspective to discuss within the ICU. And so it is, and our expenditures stop. It is, if any of us has been in a situation where that is a decision that has to be made, just think about your loved ones. Do you think you will just go and ask that machine to be switched off? Or would you rather go and give it another extra maybe day or 2? And maybe in that period of time happens before you actually decide to switch off. But the option of withdrawing an unbeneficial treatment from patients is always available when the patient no longer responds to the treatments that are being given. Over to you, Dr. Patience.
Thank you, Dr. Cornelius. The next question goes to Dr. Peter Agaba. So this comes from Peterson Steele, and he's asking us to comment about COVID-X treatment. And his issue is he asked one of the intensivist doctors where they had a patient in the ICU to administer COVID-X, and the intensivist refused. His question is it an issue of the professionals still resisting it? Please comment.
All right, thank you, Patience. So we give a number of therapies in the ICU, and there are a couple of reasons why we pick one therapy over the other. But we generally use therapy that is that has been shown to work, or that has benefit, or that has got little risk to the patient, or when compared with the benefit, the cost is worth the trouble. By the time we get someone who needs the ICU, the problems are immense. Okay, there are multiple problems, and there is no single solution that is going to work as a magic bullet. And that means that even if your patient comes to the ICU and the doctor says, let's give this patient COVID, it's unlikely that the COVID is going to be the one thing that makes the patient improve. This patient is going to require a number of therapies, and all these therapies in concert, plus the care they get in the ICU, are what are going to be important in this patient's recovery. Now, we don't, or most of us will not want to give COVID-X because, one, this is an untried drug. It has just come on the market, and there is this hype about it on WhatsApp. We don't learn medicine on WhatsApp, okay? We must first understand the drug. We want to see the drug go through a number of, tests or experiments to show that it actually gives the results that we expect. But also we want to know what harmful effects this drug has got on the patient before we give it to the patient. A lot of our patients, we are walking a fine line, and we are just balancing things. We don't want one thing to tip the patient over, and then we lose the patient over something. Okay, but we also want to be able to trace back the problems. If we add COVID into the mix of the huge number of drugs we are giving, we don't know how it's going to react with the other drugs, because this is a drug that is largely unstudied. Okay, and we don't know what its effects will be like on our patients. So until we have some more convincing evidence about it beyond the things that we see on social media, it's not a drug that we are likely to use. Okay, and this is simply because what you see on social media is largely people saying they have used the drug and they have gotten better. But I could give you multiple other numbers of patients who haven't used the drug and have gotten better. So you have to understand that there is really no one has shown a good relationship that any doctor worth his salt is going to want to use this drug. Okay, so at the moment it is still in the realm of social media. It's not in the realm of sound medicine. Thank you.
Thank you, Arthur. This question, I'm going to pose this to Dr. Elizabeth. I've seen quite a number of questions asking about how many anesthesiologists are currently in Uganda for a population of 42 million. What's the cost of training a single specialist? And in addition to that, how many anesthesiologists are working in the upcountry hospitals, that is outside Kampala, and what their experience and survival rates are? Dr. Elizabeth, if you don't mind.
Thank you, Dr. Patience. As per our last count in 2019, we had 75 practicing anesthesiologists. I believe some have left the country, others have gone for training. So I think currently we have about 68 practicing anesthesiologists for a population of 42 million in Uganda. Cornelius already alluded to the fact that a lot of the places up country have not yet been operationalized well enough to basically have us work there, but that is work in progress. It takes about 3 years to train to fully train an anesthesiologist, which is after they've actually not 3 years, because you do your medical degree, which is 5 years, you do your internship for 1 year, and then you do a master's degree in anesthesiology and critical care for 3 years. So that's about 9 years so far. And then a lot of us go abroad and do a bit of super specialized training. And that's how you have people who are interested in critical care or do specialized training in cardiac or pediatric or neuro or whatever it is that they do. And this runs for about 6 months to 2 years. So in total, it takes about, give or take 11, 12, 15 years to fully train an anesthesiologist in a super specialty. Altogether, that costs about 210 million Uganda shillings. Just to get someone at that point. So I've seen quite a number of questions, people asking, why are you so few? Is it because there are no scholarships? Is it because it's a profession that is not, the uptake is not good? Or is it because people are scared of the stress that comes with it and, the mental toll that it takes on you? I think that there are so many reasons. I actually believe that's one of the surveys we need to do and see why people would not like to take up that. But there's so many challenges that are involved in training us. And what we are glad about is that the COVID-19 pandemic has sort of brought that to light. I believe that after this, or by the time the pandemic ends, there'll be a lot of strategies in place. 1, to train more people, 2, to operationalize the ICUs up country. About the anesthesiologists who work up country, quite honestly, I'm not 100% sure about the number, but I know that they're quite small. The number is quite small and they're not enough. I think we have 1 in northern Uganda and about 2 in western Uganda. So they're not very many. About our mental health, one of the things that we're doing as an association is basically teaching people how to build resilience and teaching people how to basically take a break when they have to. I know that it's very difficult for us, especially in times like these when there's a pandemic raging and we have the skill set that we have, but we're also learning to take care of ourselves. What that means is we take a break when we need to, we take care of each other, we read articles, try and find how best we can help each other. We're also advocating for a lot more training, for funding from the government, funding from different partners, but also advocating for just, trying to interest people into coming into our specialty. I believe that the pandemic will not leave us the same. I hope that we will have more numbers of anesthesiologists the next time we have to talk about ICU, maybe in a few years. But for now, yeah, I think I hope I've answered the question. Over to you, Pesh.
Thank you, Elizabeth. I'm trying to see. So I've seen quite a number of questions about what effects both ICU and COVID-19 has on these patients' respiratory system, especially the lungs, and why is it that they tend to come back with complications, and some of them actually die even from home post ICU discharge. Dr. Kwizera.
Thank you, Dr. Tumanya. Well, what they're describing is what we call long COVID or post-COVID. There's 2 things. There is a situation where they presume they're healed, and they or the health workers presume they're healed, and if it's at home, when I say they, if it's at home, they've recovered, they think they're okay, they're over the storm, the fevers have subsided, their body pains have subsided, and they go about their normal duties. And then they end up getting again afflictions of the respiratory system, respiratory failure and so on and so forth, and succumb. Then there is where the healthcare system assumes they have done, because that's what I talk about long COVID. However, you also have situations where you have false negatives, where patients are discharged because everyone presumes they have recovered, when in actual fact they have not. And with the variants that we're having right now, where we used to say, just wait for 4 to 6 days, then your symptoms will come, and then you can determine how you will be with those symptoms. Now, with this variant, the symptoms, this variant doesn't read the textbooks we just wrote. So you'll find that, you test positive today, and then you think you've survived the 6th day, and then day 10 to 12 or 14, that's when your symptoms come, and then there's unhappiness. So what the Ministry of Health is now doing through its case management is they are setting up what we call post-COVID units. Mulago National Referral has a post-COVID unit at its facility where you go for reviews. The problem with COVID is that regardless of your symptomatology, it does infer some degree of lung damage on you. And therefore, even if you've been on low levels or you've required less oxygen supplementation to survive, you probably need to go visit the post-COVID treatment unit. The one I know right now is at Mulago. So that they do assessments on you to look at your lung function to ensure that you're able to have a good quality of life even after COVID. That's what I would advise right now. So for anybody who has survived COVID, who was symptomatic and survived COVID, I would say please go to Mulago and look for Dr. Bruce Kirenga or Dr. Frederick Nakwagala, or just for their unit, and ask for the post-COVID unit so that you get some assessment and just make sure that you're out of danger. Thank you.
Thank you, Dr. Arthur. I've seen about 2 questions of people asking what's the difference between an HDU and an ICU. I think Dr. Agawa Peter, please take that one.
All right. The difference in an HDU and an ICU is really meant to give you the full spectrum of support for any length of time. But an HDU really is for someone who needs less support. Maybe you just have one organ failing, or maybe all they need really is just to be monitored more acutely because maybe they're at risk for getting worse or not. So there may be some differences also in terms of staffing. In the ICU, we tend to want the nursing ratios to be 1 to 2, 1 nurse to at least 2 patients, or even as good as 1 nurse to 1 patient. In the HDU, 1 nurse may be handling 3 patients, and that's usually because those 3 patients are not as demanding as the patients in the ICU. Also, high dependency units will, if they have a patient who really needs a lot of support, they're unlikely to keep that patient beyond 24 hours. They will usually look for space in the ICU if they're unable to provide that in the unit. So it's it may be, depending on the hospital, sometimes the HDU is a physically different unit, but in some other hospitals, the ICU and the HDU are housed in the same unit. And it is only when the patient's requirements reduce to the level, when the care, when the acuity of the care or the load on the staff is lower, that they say, okay, this patient we can now downgrade to the high dependency unit, but they may not actually physically move the patient out of the unit. Instead, this patient may be off the ventilator. They may be requiring fewer drugs. They may be, being rehabilitated now to be even moved out of the unit altogether. I hope that answers the question.
Thank you, Dr. Peter. This goes to Dr. Kwizera. So this is from Buyinza, and his question is, who really needs critical care? Who qualifies to stay in an ICU? In fact, even before COVID-19, most patients were quickly advised to be put in ICU. Oh, so currently more patients are being advised to utilize ICU as compared to 10 years ago. We also hear of cases where there's no specialized care in the ICU, hence making us doubt the purpose of intensive care. Dr. Kwizera.
Thank you, Dr. Tumanya. Okay, so there are indications for ICU admission vary, but let's talk about the ones that we know are physiologic. When I say physiologic, means absolutely have to happen. So like Buyinza has alluded to, if you need ICU, that means you principally need respiratory support. You either need a ventilator, you need and more than just regular oxygen therapy by a mask. We have other indications for ICU admission. Your doctor might be very worried about your condition and admit you to the ICU so that you're monitored. Either you have very bad high blood pressure. A population where high blood pressure might be threatening is if you have a stroke, or if you, for example, in our mothers, you have eclampsia or not eclampsia, but preeclampsia. Preeclampsia is a condition where you have mothers who are expecting babies, are pregnant, and then develops sudden high blood pressure. You may be, you warrant admission to the intensive care unit, so you're monitored. And there are others. For example, if you have had a cardiac arrest and you've recovered, you get admitted to ICU, even if you think you're well, but you have to be monitored. If you've fallen from a height or you've been unconscious for a few minutes and then you recover, you will get admitted to a unit. Like Dr. Gawa says, you may get admitted to a high dependence unit. Some hospitals do not have that distinction. So they'll admit you to their ICU because they don't have a high dependence unit. So it's just as well. Just accept, get admitted, and be monitored. Then we have what we call, unfortunately, what we call political admissions. But I'm not going to that right now because it's not the scope of this discussion. But it does happen. If there was a story from a country, I think the Philippines, where the president got a pain in his elbow because of an injury he got from tennis and he was admitted to an ICU. But that's why we call them political admissions. So the indications for admission to the ICU dictate that. When he says, when you ask that who gets admitted there. There was a second aspect. Dr. Tumanya, what was the aspect?
Sorry, so the person was asking why there are more patients being referred to the ICUs currently as compared to 10 years ago. Yes. And there's also the mistrust that is happening. between the public and the intensive care unit's purpose.
Yes. So the reason why there's an increased referral, and I'm glad he mentioned a 10-year difference, is because life expectancy has increased, and with increased life expectancy, you also have decreased physiologic reserve. Because one of the issues with physiologic reserve is that older people are less able to deal with insults, and therefore they are more likely to be admitted to ICU, even if it's something simple. The distrust or mistrust with ICUs, yes, I'm sorry to say, may exist because of the nature of, we're the 24th poorest country in the world. People cannot afford intensive care. And when we have a challenge with intensive care services being met by, let's say, the public sector, there's extreme competition for private sector services. And then it's human nature for us to build theories or conspiracies. And remember, intensive care right now, unfortunately right now, is not that well regulated. And so the mistrust comes because money is spent. And so it doesn't matter the industry, whether you're going to spend it on intensive care or restaurant bill, you're going to have doubts, especially if you feel that you're paying too much for a service you feel should be basic, or you didn't get the most out of. So that's how I will say it. And also there are unscrupulous, hospitals that may want to profit here out of this. I'm not going to rule that out, but I hope that this session might help us in that direction. Thank you.
Thank you, Arthur. So I've seen quite a number of questions about which cadre work in an ICU. Is it only anesthesiologists? And probably just to have that out of the way. So the ICU is really run by multidisciplinary teams. You can have intensivists that are of an anesthesia background, who are the majority of the cadres that run the ICU. You can have intensivists or internists with an internal medicine background. Those can also run the ICUs. You can also have people with a surgical background, also, super specializing in ICU care, and they can also run, they can also participate in the ICUs. But overall, for all the intensivists that are working, if they have a need to consult another physician or a surgeon or someone else, clinical pharmacists and nutritionists, all those are literally part of the care of an ICU patient. The next question was about the cost of oxygen. Please give us a picture of how best the provision and procurement of oxygen under COVID is being met or remains a challenge. Are there any alternatives before or in the ICU? I think this is, we can post this to Dr. Cornelius.
My apologies, my network is a bit shaky. May I hear the question again, please?
So the question comes from Cornelius. He says that he has questions about the cost of oxygen. Could you give us a picture of how best the provision and procurement of oxygen under COVID is being met, or does it remain a challenge? Are there any alternatives before or in the ICU?
Okay, good question. Okay, first of all, I think how it's being met, I'll leave that to hello. Yeah, so I think let me start by saying there have been so many countries that have suffered.
I'm just buying one thing real quick.
Dr. Peter, please mute your microphone. Dr. Peter.
So the cost of oxygen, the oxygen capacity in most countries at the peak of COVID-19 a majority of countries actually experience a deficit in oxygen. And that's because the world had never really prepared for such a scenario. And therefore, it's understandable that the deficit would exist even in high-income countries at the peak of the surge. Now, for countries like Uganda that have to rely a lot more on other high-income countries, it becomes a very difficult situation because, first of all, we do not make oxygen plants here. We don't particularly make liquid oxygen, and we do not make any devices that make oxygen. And so that means everything regarding oxygen has to be imported. And that comes with a lot of challenges and limitations. And so it's important that on that background, we understand where we are as a country, and then we understand that maybe about a year ago, when an oxygen capacity assessment in Uganda was done, it was clear we did not have enough oxygen based on the projections that were run at that particular time. If you have a patient on just 5 liters of oxygen, and then say regional referral, and you multiply that by maybe 30 patients on 5 liters of oxygen, what is the consumption in a regional referral hospital? And is the production in that regional referral hospital that has an oxygen plant enough to cater for those patients? And we're actually really falling short even in that regard. So oxygen currently is, again, the cost of oxygen is being driven up by the supply and demand nature of the economy. And therefore you'll find that a cylinder, filling up a cylinder, one of those large cylinders, was initially quite cheap, about less than 100,000 shillings, is now approximately 250,000 shillings and above. And that's because the demand is really high. And that, of course, there have been various ways to try and offset that. Of course, places like roofings have tried to do CSR and provide it for free, but definitely you'll find a long line waiting. If you have a dying patient, that long line is not what you want. You're probably going to go and try and buy it somewhere. And then, of course, the UPDF, I think, also started to produce oxygen. And so there have been a couple of efforts to try and mitigate the costs, but certainly we have to appreciate that once the demand for any commodity goes up, it means the production rate has to be commensurate to that. And the production rate is going to lead to costs going up, and therefore the consumer, who is finally the patient, is going to incur those costs. So it's a very complex pathway to go through, and I think there are quite a number of efforts to try and mitigate this problem. Although honestly, I do not know if it can be solved as fast as it grows. Our biggest solution to this is to make sure, number one, we do not fall that sick to require oxygen, and therefore we have to follow the SOPs. Let's get vaccinated, and that will relieve the burden on the healthcare system, and then I'll give chance to the different sectors, both public and private, to be able to stock up and be able to be ready for any eventualities in case we get a third wave. So let us not be extremely shocked of what's happening right now. God gave us 21%, and we are trying to produce 100%, and therefore that is going to require some economic investment to be able to produce that. Thank you.
Thank you, Dr. Cornelius. Dr. Kwizera, there's a question that is directed to you. Can you shed more light on the realistic capacity of Uganda's health system to run and sustain ICU care outside of the private sector? Given the resource limitation, shouldn't the Anesthesiology Society advise the MOH on how best to optimize the limited resources in the COVID crisis rather than wasting them on ICU care, whose foundation structure we don't even have? Call a spade, so to speak.
Very good question. All right, I just said, okay, first of all, I will add to what Dr. Cornelius has submitted. We have an oxygen task force. This oxygen task force came up with quantifications for what would need. We created clinical scenarios, and so the Association of Anesthesiologists was involved in that. And we are doing planning and installation and building capacity for the health sub-districts, which obviously are led by regional referral hospitals. Okay. The tough question you've posed is difficult because being involved with discussions in the Ministry of Health with regards to capacity building for intensive care and understanding that we are a poor country, we have an ethos, we have a philosophy that we're developing. And members from the Association of Anesthesiologists, that's one of the things we're involved in is the research question that can't we save so many lives before the time that they get to needing intensive care. So let's call it pre-intensive care or pre-emergency care, because our emergency care colleagues would be the next step. But what you're saying is that are there things we can do in places where there is no emergency or intensive care that can reduce the need for intensive care or emergency care? And so those are some of the studies that we are involved in as members of the association to reduce on that. Okay. And we have told the Ministry of Health the same, and they're happy. They understand it, they get it. Understand that intensive care means that you can reduce all-cause mortality from HIV, malaria, TB, maternal child health, etc., which are very heavily funded areas. So what we are saying is that give us some of those resources to answer the question where we can reduce morbidity, mortality, because people die. Why do people die? People die because in Uganda, we do not get access to emergency and intensive care. So if we can do that with the resources that are portioned to the programs, then we can actually make a difference. So to answer your question, yes, it's possible. And the Ministry of Health and the association are involved in these discussions to reduce all-cause mortality by the interventions that we have proposed that do not need a building and expensive equipment and expensive human resources. Thank you.
Thank you, Dr. Arthur. Dr. Agaba Peter, there's a question about we have good experts in Uganda. Why is it that there's a perception that Aga Khan and Nairobi can do better, yet what is in TMR is the same as what is in Nairobi or Aga Khan?
Well, for me, the answer that comes readily to mind is that Ugandans love exotic things. And we also have very little faith in our own people. So we tend to mistrust what is here. And so we look outside the country for those things. And only when our options are limited do we look within the country for solutions. That's one of the reasons. The other reason may be that, you know what, some of us have had a terrible experience in the hospitals here, and that has driven us away from wanting to get care here. So maybe that is an explanation. But beyond that, I can't really tell you why people would prefer to go to Nairobi versus come here. That's not a question I think I can answer very well.
Thank you, Peter. Dr. Cornelius, there's a question about if we only have 60 practicing anesthesiologists, majority of whom are in the central region, isn't there a risk that many hospitals are operating ICUs without qualified anesthesiologists and putting people's lives at risk? Is there a regular monitoring of hospitals to confirm qualifications of ICU operating hospitals?
That's a very good question. And I think the purpose of this webinar is partly to answer questions like that. Perhaps let me start off with taking us, doing a bit of a rewind. We started, intensive care in Uganda is still quite young. I think, maybe I require some correction on this by Dr. Kwizera, but I think it's under 20 years, and that's maybe an overstretch. So until recently with the COVID-19 outbreak, and in fact, until this particular wave, we were not discussing intensive care. And therefore, the Uganda has mostly focused on primary health care and prevention of disease, which is excellent. However, there are always going to be cases that slip through and require the tertiary level of care, the tertiary care that can be provided in a healthcare system, and that's where intensive care lies. And we have not spent a lot of time discussing intensive care in the last, maybe, how old is the country? Maybe 40 something years, as we have in the last 2 months. So when we talk about the standards and the care that has to be provided, they're non-existent. We don't have them. And therefore, these are some of the things that the association is trying to work on. We have already designed, based on what is required in an ICU, we have designed an assessment tool that will allow us to check off the quality indicators in each of the ICUs, and that includes the qualification of the staff. Now, with 60 anesthesiologists in the country, or I would maybe correct that, 68 practice anesthesiologists in the country, we have less than 10 of them who have had certification, further training in intensive care medicine. Of course, by their natural training, anesthesiologists can run an ICU because of the training that they get and because of the background of the training. And therefore, when it comes to going for certification, a fellowship in intensive care medicine, anesthesiologists tend to have the shortest time of training. Maybe not, there is no program that is more than 2 years. If you look at other fields, it goes up to about 3 years of intensive care training for them to get the full certification. So naturally, because of the nature of the training, anesthesiologists will potentially be found to be running most ICUs in most countries except the US, where it's mostly run by physicians and most especially pulmonary critical care physicians. However, if you go to countries like Europe, Australia, even North America, of course, most low-income settings, Brazil, India, and all that, you'll find the majority are going to be anesthesiologists. So coming to your question, yes, there is a risk that patients will be managed by people who are less qualified, and that's why it's incumbent on you to find out who is actually in the ICU, who heads the ICU, what is the ICU team, what are the qualifications of the ICU team. And this is important because you need to know if your patient is getting the experience and the expertise of someone actually qualified to be in the ICU. Otherwise, if you find any random individual in the ICU or someone calling themselves an intensivist, but there is no verification or there is no particular qualification you can find on that in particular individual, your patient is going to be at a very high risk of mortality and very high risk of complications. So it's why it's extremely important. And I don't know if I can emphasize this even more than what I'm saying, but you must find out who heads that ICU, what their qualification is. And just because they're an anesthesiologist does not mean they cannot run an ICU. Like I said, there are other specialties, and this has also been mentioned, that have had further training in intensive care medicine. And so my advice is, if they have not had any extra training in intensive care medicine, or they are not an anesthesiologist, they have no business running care on your patient, because the intricacies of care in ICU are so expansive and detailed that you require someone with some level of expertise in the ICU to know exactly what they need to do to manage the organs. I hope that answers the question.
Thank you, Dr. Cornelius. There's a question that has recurred over and over I suppose I was trying to avoid it, but I'm going to pose this to Dr. Kwizera Asa. We've had a number of people asking about what the mortality rate is at Mulago Hospital. And with the current low numbers of anesthesiologists, what is the staffing at Mulago Hospital, and are their patients being taken care of by specialists? And yeah, and what happens to the patients who arrive to Mulago, especially when the ICUs are full? And what is the current situation at the moment? Dr. Kwizera.
Like we say in Buganda, on Padeo water. Okay, that's fine.
I am sorry.
It's fine. The question has to be answered. So, like everything else, it's supply and demand. If the demand is high and the supply is capped, you're going to get quality problems. It's just the way it is. So, if Mulago Hospital has just enough ICU beds and just enough staff, or just enough for what it thought or planned for, and suddenly you're getting 8 times that amount, then you are going to get the same outcomes, or you're going to get expected outcomes. The truth of the matter is that the mortality in Mulago Hospital ICU is a lot higher than it is in places that have the requisite resources. So if you have one-to-one ICU nursing in, let's pick a hospital, Arthur Hospital. But in Mulago, you have 1 to 6 nursing because they're overwhelmed, and maybe they thought that they would have fewer patients, and then they planned, and then said because they can't refuse anybody who is coming, their nursing levels go to 1 to 6. Obviously, mortality is going to be higher. And that is the reality. Like all public sector hospitals, we are bedeviled by reduced human capital. And I'm sorry, but that's the reality. We just don't have enough doctors, we don't have enough nurses. If you don't have a doctor at night in the hospital, in the ICU, just understand that you're going to get an additional 80% mortality. So when you hear that, oh, the mortality on mechanical ventilation is 90% in Mulago, which is close to the truth, and then you hear that the mortality on mechanical ventilation in Hospital Arthur is 20%, which is actually the truth. The question is not about the quality of care, the question is about the quantity of care. And maybe in addition to that, the quality of care. And that is the harsh reality. Intensive care is expensive care. And the largest percentage of cost goes to skilled, keyword, skilled human resource. The human resource in the Mulago COVID ICU right now are really awesome people. I can name names, they're really nice. They are working overtime, extra time. They are doing, these are patriots. Each of them deserves a medal. But unfortunately, medal does not translate to food on their table, rent, their bills, their school fees, their fuel, and other needs. And that's the harsh reality of a low-income country. So yes, the mortality for mechanically ventilated patients in ICU in public hospitals is 3 times that in private hospitals. And I have said that because of the reasons that are not blamed to anybody else, to anybody for that matter. It's just how it is, and we can now go to the solutions, but that's how they are. Thank you, Dr. Patience.
Thank you, Dr. Arthur. Probably just to get a little something lighter than the medical thing. So we have a question quite interesting from Angasha Dennis, and he says, away from the critical bit of care, I have interacted with up to 5 individuals who say that they are facing erectile dysfunction and are in fear of losing their wives because of COVID jabs. On the other hand, some people have reacted terribly to the jabs and have even lost their wives. What's your take on this? I will leave this to the males to decide. Dr. Cornelius, Dr. Arthur, Dr. Peter.
Maybe let me go first before the rest. I think thank you for taking us off the path from this, but I'm not aware of any data that has suggested that particular side effect. I think Dr. Arthur and Dr. Peter, being males, can also attest that their capacity to function as males has probably not dwindled. I could be wrong, but I do not think the concern is related to that. That is my submission. Maybe we shall get more data in the future, and maybe we have very small sample size to go with, but I have not heard of any of my colleagues, males to be precise, having these particular complaints. And so these could be coincidental findings and not associated with the vaccine. I hope that answers the question.
Thank you, Cornelius. Dr. Arthur and Peter, are you having issues that we should hear about?
What was the question? Please repeat.
The question was, most of the people that he knows who have received the COVID-19 jab are having erectile dysfunction and they're losing their wives. And he's wondering if, yeah, if this is something that is common to other people, and yeah, he wanted some clarity.
All right. I think my answer would be the same as Cornell. There's no data to show that. On a personal level, I don't have a wife to lose. This may be a good thing. But I also have had both shots for the vaccine. I haven't experienced any problems besides the usual, fever and some pains, and that's it. And that goes away within a couple of, within a day. So no, I don't think it is related to the vaccine. It may be related to some other things. If your wife is leaving you, maybe there's something else beyond. Maybe it is stress. But anyway, not to get into that. I think things like erectile dysfunction have a lot more. You need to dig deeper for what's going on. It's usually not what you see on the surface that's causing these problems.
Would you like to comment about steroid use in regards to that? Maybe there could be a correlation there.
No, I don't want to make a comment. I don't think I know enough to make a comment on that.
Dr. Kwizera, steroid use and erectile dysfunction or reduced libido?
Well, testosterone is a steroid, but with vis-a-vis the vaccine, no, there's no correlation. What I would tell the person who's posted this is to focus on, to look at the numbers. When they say, when he or she says that they have encountered a number of people who have erectile dysfunction as a result of the vaccine, then that is, if they think, if they can correlate it properly, they should report it to the National Drug Authority under the adverse events, fill the adverse events form and share it. However, there's no data. This is the first time I'm seeing or reading this, and as much as we cannot discount it, it's probably for now not linked to the vaccine. With regards to steroid use, no, because the problem is with if you give yourself an exogenous steroid, your body's negative feedback mechanisms will come into play. So if you're naturally acting testosterone are okay, and your body notices a surge of other steroids, it will kick a negative response on the other side in a perceived effort to counterbalance, and therefore knock out the positive testosterone reflexes, which include libido. So thereby knocking out the steroids, your libido. If it is corticosteroids in this respect, when we're talking about whether it's hydrocortisone, dexamethasone, yes, they will do the same thing. So understandably. Over.
Thank you, Arthur. I guess just to clarify, the person who asked that question has said the numbers were about 5, so a small number. But yeah, I guess that happens. One Kamgisha is giving a suggestion that please don't dissociate erectile dysfunction from the vaccine, since you can't associate it. Well, I guess that's what Arthur's summary was. We still have quite a number of questions. I'm going to try and see how we can go through this in about 10 minutes tops. One of the questions is, why do patients deteriorate in the afternoon and at night? Some COVID patient told me that he would fear to sleep at night. What is your advice on sleeping patterns for COVID patients? Dr. Cornelius?
Okay, that is an interesting question. Unfortunately, I have not seen the pattern of dying during the afternoon. I think it's more of a pattern of night, and there are so many reasons associated with nighttime mortalities. So starting globally, and before I go into my hypothetical thoughts, starting globally, the night shifts tend to be less well staffed generally, but also there's perception that they may have less experienced staff. So for example, some night shifts may have maybe senior trainees, or they may have fellow people who are training in critical care. We call them fellows. And then of course the availability of resources in the night may be relatively low. So these are mostly nighttime mortalities are mostly associated with the system, perhaps system failures or system gaps. But there may be other factors that are patient related that may increase the risk of dying at night. For some reason, during the day we have a much higher level of cortisol that is secreted, and this is a hormone that our body secretes under stressful conditions, and it helps us to sustain a lot of things within our body and our bodily functions. And at night it tends to drop quite significantly, and that in itself may, and this is purely hypothetical, study confirming this hypothesis, but it could potentially explain why critically ill patients who are naturally depleted of this particular hormone in some instances, especially when they have very severe infections, may actually deteriorate at night and die. And it may also explain why most of our loved ones who are really sick, whether they're in the hospital or not in the hospital, could potentially die at night. So that tends to be not limited to COVID-19. It tends to be broad to just being really, really sick.
Thank you, Dr. Cornelius. Dr. Peter Gaba, I'll give you 2 questions. How can village people access ICU care? And 2, Besides underlying medical conditions, what are the current key factors, e.g. age group, gender, that are influencing the outcome of COVID-19, that are influencing COVID-19 ICU outcome?
All right. The first question was, how can village people access ICU care? Village people, meaning people outside Kampala, meaning what do they mean? People who are of a certain social status. People outside Kampala.
Rural?
Yes, rural. So if it's in regards to COVID, usually it's going to be a referral from the treating physician to escalate care, and they will want to find out where can they access ICU care. These days, the easiest thing is to go through the emergency medical services, for which there is now a toll-free number. And once the referral is made, the EMS service then assesses the need for ICU, and then also assesses their priority, and then they will determine where they can take the patient if there's ICU space available. For most of these, for most patients, I mean, if we're talking village patients, then the assumption is that they may not be able to afford the type of care that is in the private hospitals. They're usually going to be routed to Mulago. And that means now everyone is going to be competing for just a handful of beds in the unit. So then access now depends on a host of things, including their benefit, whether they are sick enough to need the ICU and whether they are not too sick to need the ICU, in the sense that are they beyond salvage? Okay. Now, the truth of the matter is, it's difficult to get ICU when there are so many people who require the ICU, and it will probably be even harder for people from the village to access ICU, simply because they are fighting for fewer beds than those who have got more resources available to them. What was the second part of the question?
Sorry, I've forgotten. My bad. We need to look through.
All right, I think I will leave it there then.
Yeah, sorry, I can't get it. I had already cleared it. So this brings us to the end of our session. We thank you all for attending. Perhaps
Patience,
one of the
before you
questions we
end.
hadn't. Yeah, okay. Yes.
Oh, yes,
Liz?
the other question, Patience.
Okay, let Agaba go ahead.
Sorry, Liz. The other question had to do with risk factors for mortality.
Yes.
Yeah.
Yes.
The known ones are going to be increased. Well, are not going to be, but are usually increased age. The comorbidities that they have, especially if it's they have got high blood pressure, they've got some form of heart disease, if they are diabetic, if they are patients who have had some form of renal transplant or an immunosuppression, patients with various other comorbidities usually are going to be have a higher mortality. Patients who are obese, those are the known ones, and maybe, of course, yes, the male gender are more likely to have poorer outcomes.
Thank you. There's one question that seems pretty important. We shouldn't leave without talking about it. It's in the chat room. Someone is asking, What is the proportion of vaccinated people who require ICU care?
No one has that data.
Dr.
But let Liz answer.
No,
please go ahead.
Please go ahead.
I was going to say no one
Doctor?
has the data, but maybe I am wrong. Maybe someone has the data. The Ugandan numbers. I will say though that I have seen just one patient in the ICU who was fully vaccinated. At least the card said he was fully vaccinated, and this is more than 2 weeks beyond his last beyond his second shot. However, I think the person asking this question is concerned about the efficacy of the vaccine. What I will say is that you have to look at what what the numbers show, and what the numbers do show is that the vaccine is protective. There are going to be failures, okay, where some people may get both the shots and still get the disease, and may even still get very sick enough to need the ICU. Those are going to happen. And that's simply because there's nothing perfect in this world. The vaccine itself, you may get, we don't know if you get the right vaccine. We don't know if the vaccine is handled properly before it is given to you. And all those things introduce errors along the way. But by and large, for most people, the vaccine is going to be protective.
Thank you, Dr. Peter. Dr. Cornelius, you had something to say?
Yeah, not so different. Maybe let me just say that that we do not know, like Peter said, but we also know that about 5% of the population has been vaccinated. The majority of the patients in the ICUs are actually not vaccinated. But there is a study that is going to be conducted, and I think this is by Professor Viachika and Dr. Bruce. That team is going to conduct and see how many patients actually were vaccinated and ended up in the ICU. So we shall probably have better figures then, but I can almost bet the biggest number is going to be the unvaccinated, simply because over 95% of the population is not vaccinated. And also because the pattern that we've seen in the ICU are patients who are not vaccinated.
Thank you, Dr. Cornelius. Dr. Elizabeth, you had something to say before we close?
Yes. A lot of people have been asking, how do they contact us? How do they get to us? How can they get this recording? The recording is going to be uploaded to our YouTube channel. If you just go to YouTube and search for Association of Anesthesiologists of Uganda, you should be able to reach our channel and be able to see this recording and a few other recordings that we've done in the past. We also have a website. I'm trying to get the link and post it, but just in case I don't, you can still type in Association of Anesthesiologists of Uganda into Google and be able to find our website. We have an office in Bukoto. We share a building with the Association of Gynecologists of Uganda. It's in Bukoto, just near the Bukoto apartments. And we have an administrator whose contact is on the website. So if anyone wants to contact us, please feel free to do that. However, also in the different hospitals, just in case you need to contact an anesthesiologist, there should be one, and they should be able to give you a contact of our organization. Back over to you, Patience.
Thank you, Elizabeth. Thank you all for attending this. This has been quite interactive, and I hope we've shed some light on what ICU is. But before we leave, to just make a conclusive remark, is to just be aware that ICU is not just a location in a hospital. Most of the contributors to the outcomes we get from these ICUs will depend on, the pre-hospital care, the in-hospital care that is outside the ICU, and all these, the emergency care, the care on the ward, the rehabilitations, the post-ICU care will really, really, really play a big role to how our patients leave the hospital and how they survive, or to put it in better words, the quality of life after the ICU care will really be based on very many factors that is not really tailored to just the ICU care. Thank you very much. And I think I'll bring this to the end. Goodbye.